Okay, thanks to everyone for joining us today for another edition of our mini grand rounds. My name is Bettina Burias. I'm the lead communications person here at the Annals of Family Medicine. And as always, our aim is to bring you the latest research in family medicine in under 30 minutes. We know everybody's busy, so we're going to try our best to keep to that time. For those who have joined us before, today's session is going to look a little bit different. In addition to the lead author of today's paper, we're joined by a notable expert in the field of rural health, Dr. Jan Probst. Dr. Probst is a distinguished professor emerita at the Arnold School of Public Health at the University of South Carolina, where she also serves as associate director of the Rural and Minority Health Research Center. She'll serve as a moderator for today's discussion, which is a new feature for the mini grand rounds format. So as she's asking questions and making comments along with during the presentation, please share your thoughts and comments with us and the team here in the chat. We'll be keeping an eye on the chat box and are looking forward to hearing your questions. With that, I hand things over to Dr. Probst to kick off the mini grand rounds with a quick comment and introduction of today's lead author.
Well, thank you. Thank you so much for this opportunity. I am so delighted that the Annals is featuring a presentation that deals with rural health, because that is basically what I've been doing, for the last 20, 30 years. So it's really close to my heart. And I will say, what the exciting young researcher I'm going to introduce you to, I was approached by Annals and asked, would I be willing to moderate a discussion of a particular study? And I had already read that study and thought, wow, this person did a great job. This is a method that usually isn't done well, and they did a bang up job of it. So I am here to say that I would not be here if I did not believe that Dr. Elizabeth Golembiowski really is a good researcher and someone who has made interesting contributions to what we know about rural health. Dr. Golembiowski is currently at the Mayo Clinic in Rochester, Minnesota, in the Department of Endocrinology, diabetes, and nutrition. She completed her PhD in health policy and management at Indiana University, focusing on studying the intersection of Medicaid policy and housing. And before that, she got her MPH from the University of Iowa, where her interest in rural health was piqued while working on projects related to SNAP programming and school meals in rural areas of Iowa. She is a mixed method researcher, which for those of you who are physicians, that means you do some counting of things, you do some in-depth studying, in-person studying of things. It is rare to find people who can put the two of those together well. So, which is why I'm very excited about Dr. Golembiowski's study, which combines the quant aspects of doing a systematic review of the literature with the qualitative assessing and looking at things and saying, what does this mean that we can share about rural patients? And with that, I will turn the discussion over to our main presenter.
Thank you so much, Jan, for those kind words. Really appreciate it. And please interrupt at any time if something's off with my slides. I feel like after 2.5 years, I still make a lot of mistakes on Zoom. But as Jan said, my name is Elizabeth Golembiowski, and I'm a health services analyst at the Mayo Clinic in Minnesota. And today I have the pleasure of sharing some findings from a systematic review of qualitative studies we did, focused on the experiences of rural patients as they access and use healthcare for chronic conditions. This was recently published in the Annals of Family Medicine. Let's see. So I, of course, have to start by thanking our very large and very fantastic team of researchers, trainees, and clinicians who kept this review going during the pandemic and other interruptions, including my maternity leave, I think. This was a great team effort. So thank you to everyone involved, and thank you to the Mayo Clinic CCATs for funding this work. So I know we're limited on time, and many people on this call are likely familiar with the issues facing rural patients today, but I just wanted to give a brief overview of some of the motivation for looking at this topic. So improving rural health has nominally been a longstanding policy priority in the US but many rural-urban disparities in chronic disease have remained pretty sticky to change or even worsened over the past decades. Compared to urban and suburban metropolitan areas, rural populations have a higher prevalence of most major chronic diseases. For example, one estimate puts the prevalence of diabetes in rural areas as much as 17% higher than in urban areas. In addition, there's a much higher prevalence of multimorbidity or having two or more comorbid chronic conditions among rural residents. Rural patients are more likely to die from reasons attributable to chronic disease. And although excess mortality rates from chronic disease have been on the decline overall, over the past several decades, rural areas have seen a much slower decrease than urban areas. And these differences are likely driven by some pretty persistent structural and social inequities in wealth, poverty, unemployment rates, and of course, healthcare access, which is the focus of our review. So of course, access to healthcare is a very complex concept that's been the subject of much debate in the literature. It's got a range of definitions and frameworks and measures. So just broadly, without attachment to any particular framework, there are several common and pretty well-established barriers to healthcare access among rural patients with chronic disease. Of course, by definition, these include long distances to care settings, as well as limited transportation options to get there, shortages of primary care, mental health, and specialty clinicians, resources and services, aging infrastructure and technology, inadequate levels of high-speed internet connectivity that would enable virtual healthcare services, a constellation of socioeconomic factors like high rates of unemployment and poverty and lower rates of health insurance coverage than in urban areas, and cultural norms related to healthcare seeking and privacy. So given all that, what can a qualitative review tell us about rural healthcare access that hasn't already been, been explored in descriptive research? So many of these factors that influence access are fairly quantifiable to different extents at a population level. So we were really interested in exploring the lived experience of accessing care for chronic conditions, which is less readily characterized when we're having discussions about rural healthcare. So a systematic review and then a synthesis of existing qualitative research allows us to provide some more context and nuance to these measures. It can describe both disparate and common experiences among rural patients who are actually a very diverse group, provide new insights into how healthcare organizations and individual clinicians can support rural patients in chronic disease management, and then identify opportunities and challenges for future research in this area. So our objectives, as I said, were to systematically review the qualitative literature and then to synthesize themes across these primary qualitative studies. So just briefly, so you have a sense of what we were looking at, we included peer-reviewed studies published in English from 2010 to 2019, which means that these are all pre-COVID studies, something to keep in mind. We determined rural residents based on the authors or participants' self-categorization as rural. We sought studies that used any qualitative methodology for the purpose of exploring participant experiences and perceptions. All included studies had patients themselves and or an unpaid caregiver, like a spouse or family member, as the participant. So we excluded any studies that were solely of clinician or policymaker perspectives if they did not also contain a reported patient or caregiver component. We used the AHRQ criteria for chronic conditions, and we also included studies focused on patient experiences of having multiple chronic conditions or multimorbidity without a disease-specific focus. And lastly, and probably most importantly, our focus was on studies that were focused themselves on patient experiences of access to or use of healthcare resources and services And this in particular was a pretty tough aspect to standardize as we went through the screening and review process, and involved lots of ongoing discussion as a team. And finally, given the conceptual and practical overlap between access and utilization, we took a pretty broad approach and included studies evaluating aspects of either or both. And I won't go into too much detail here about the methods, but happy to answer any questions afterwards, since this is a qualitative review and synthesis is a method people tend to be unfamiliar with. Basically, our methods for the actual literature search followed standard practices for screening, review, data extraction, creating a search strategy, etc. And then for our thematic synthesis, we followed an established 3-step process of basically looking at all the data from included studies. This our kind of codable data that we used for analysis included any quotes from participants from primary studies, summaries of participant responses, and interpretive statements by the study authors. So basically anything published under the results or findings section of primary studies. And then our process from there, actually looks a lot like analysis of primary qualitative data. So we developed a code book that we iteratively piloted as a group and coded line by line. We developed these coded excerpts into descriptive themes, which we then further organized into larger analytical themes. And those are what I'll be focusing on today in our findings. And so here is just an overview of the descriptive characteristics of included studies. We ended up with a final set of 62 different studies with over 1,300 participants, mostly patients, but also a few caregivers. As you can see, cancer of any kind comprised nearly a quarter of studies as the disease of focus, followed by behavioral health, which we use as a broad category encompassing chronic mental health disorders, as well as substance use disorder and addiction. Interestingly, HIV/AIDS was well represented, which I say is interesting given that HIV is one of the few common chronic conditions that is actually less prevalent in rural communities compared to urban areas. But as you'll see in our thematic synthesis, there are some unique concerns related to privacy and stigma in rural communities that make it a particularly rich issue for qualitative exploration. And then this variable special populations was a designation we created inductively after all of our other descriptive data were extracted. It's meant to describe the study focus on a specific demographic or cultural subgroup. Although there were a handful of studies focused on Black or Hispanic populations, Native American or Indigenous patients was by far the most common specific racial or ethnic group of focus among included studies. Also, Appalachian was another distinct cultural group that emerged in our data, which is interesting because as I found out, only about 10% of Appalachian residents actually live in rural counties, but it's such a high profile cultural group, which I think is why, we saw a lot of it in this work. And speaking of, we looked at the geographic spread of included studies by census region and found that over half took place in the southeastern United States, which tracks almost exactly with the actual distribution of the rural population in the US. So as I was saying before we started, this is a lot to fit into a short presentation, so I'm going to try to move quickly through the findings from our thematic synthesis. We identified 4 higher level analytical themes across all of our included studies, with more narrow descriptive themes organized within each of these, as you see in the black headers. So our first analytical theme is what we titled Navigating the Rural Environment, which sort of encompasses how the characteristics inherent in living in a rural area can influence healthcare access and use. So as you can imagine, a majority of studies described the impact of geography and distance on access to care. In addition, the burden associated with lengthy travel to seek healthcare services was compounded by not feeling well because of flares or symptoms of chronic conditions. Social support was an important driver of physical access to care, particularly among patients whose health made lengthy solo travel difficult. Spouses, adult children, and friends or neighbors played a critical role in supporting healthcare access. But conversely, lack of social support was a practical barrier to care, and some patients worried about leaning too hard on their networks for rides and support in that area. And finally, many patients described a willingness actually to travel additional distances for healthcare in cases where they felt like the quality of their local clinicians, technology, services, clinics, et cetera, were suboptimal to meet their healthcare needs. In particular, more medically complex participants felt that local primary care clinicians were not as well equipped to manage their ongoing medical needs. Other participants described seeking care far from their rural community for the purpose of ensuring confidential treatment for sensitive or stigmatized conditions like HIV and AIDS, substance use disorders, or mental health care. Our second theme describes patient experiences with features of the healthcare system itself. Patients across studies described significant issues with maintaining continuous care with specific providers, as well as difficulties juggling appointments and communication between providers and clinics. Many patients cited delays in needed care due to clinician shortages and limited availability of specific providers. Many patients were also frustrated by the inability to see a trusted, established clinician and having to be shuffled through multiple providers within an organization, depending on staffing schedules. Patients in many studies also described further frustrations with inflexible scheduling and having to wait in the clinic for long periods of time after spending a lot of their day to just get there. Some participants did describe efforts by their health system or their individual clinicians to improve their access and experience of care and coordination between providers. These were things like co-located services, after hours phone lines, patient portals, and patient navigators. Our third theme is related to struggles that rural patients expressed in terms of financing their healthcare for chronic disease. A pretty common complaint was the fact that living in a remote area sort of intensified the already high costs of healthcare services, given all the additional costs associated with transportation, overnight lodging if you had to stay the night somewhere else, away from home, and then time spent away from work and childcare. Actually, NPR ran a story earlier this week about the disproportionate effect of the current high gas prices on rural areas, because there's effectively no public transportation in most rural areas, and so residents rely on driving to get where they need to go. So patients also described many competing financial priorities related to household expenses and childcare, as well as the associated anxiety of making these economic trade-offs. These ongoing affordability issues were positioned against a larger picture of economic hardship in rural communities, and the constant stress of living paycheck to paycheck in turn was felt to take a toll on health. And finally, health insurance coverage was, as you can expect, frequently described as both expensive and inadequate. Many patients expressed further frustration with the administrative burdens related to proving their eligibility, providing documentation, and ensuring that preferred providers and medications and services would be covered under their plan. And specifically among Native American participants, something we saw come up quite a bit was that even though they are covered under the federal Indian Health Services program, obtaining services and medications and specialty care outside of the Indian Health Service scope was often expensive and difficult. And then our final larger analytical theme was what we probably uncreatively termed rural life. So despite some of the challenges already described, there were across kind of a range of subgroups and geographic locations and distinct areas of the country, there were some pretty common elements of a distinctly rural way of thinking and behaving as they relate to health and healthcare use. So despite all of the challenges to getting healthcare, many participants in included studies noted that they enjoyed the close-knit nature of their community and the high levels of social support that they got from family and neighbors. One participant stands out who memorably described seeing his doctor at church on Sunday and getting a prescription on the spot for a cat bite, noting that that was something that would never happen in a bigger town. But this sense of a tight-knit community proved to be a double-edged sword for some participants, as this closeness created a lack of personal privacy. In fact, nearly all of our included studies that focused on sensitive or stigmatized chronic conditions, like HIV, AIDS, and mental health, mentioned lack of privacy as a significant barrier to access. Self-sufficiency, hard work, and stoicism were commonly noted as distinct rural cultural values by patients. Several studies explored themes of chronic disease as a failure to live up to one's responsibilities in the family or community. In turn, this expectation influenced individual care-seeking behaviors and attitudes. And there was this attitude of powering through chronic disease that we saw come up quite a bit, and reluctance to seek formal healthcare services. And then finally, there was a desire for greater cultural sensitivity and understanding among healthcare providers and support staff. This was particularly seen in some of those demographic subgroups I mentioned, like Native American patients, who characterized Western clinicians as sometimes paternalistic and condescending, and also inadequately versed or trained in tribal health-related beliefs, preferences, and social norms. So I think we're getting low on time. Like I said, this is a lot to kind of distill. But basically, our main takeaways from this was we did see a high level of agreement with those, more well-known traditional metrics related to access, things like distance and travel time, clinician availability, financing care. But hearing from patients themselves across such a broad, set of studies suggests that there are some nuances that might be overlooked by traditional metrics. So for example, knowing the average distance to the nearest clinic doesn't tell us a lot about the individual patient experience of needing someone to drive them, needing to find a reliable vehicle and fill it up with gas, or weather conditions that would prevent safe travel. One of our major findings, as you see here, is it might be worth the extra distance, travel, and cost for some patients to go the extra mile to obtain care from clinicians who they feel more adequately fit their needs, values, and preferences for healthcare. In turn, this is something that might exacerbate existing disparities in health outcomes between rural patients who can afford to travel elsewhere and those who can't. And as I've described before, we saw that some pretty distinct rural cultural norms influenced the way that patients tended to seek out or not seek out formal healthcare services. Something that was notable is we saw very little attention in these studies devoted to telehealth, which I know is a huge buzzword in the conversation about improving rural access. So I was curious just to see the lack of qualitative work focused on things like patient attitudes or use of telemedicine services. I'm sure that's been, well documented outside of the qualitative literature. But hearing from the patients themselves is important for getting a sense of acceptability and best practices. Of course, there are also significant challenges to telemedicine in these areas because of lack of reliable broadband access and lower rates of smartphone use. And then from a research perspective, a minority of studies used remote modes of data collection, including just using the telephone. In-person data collection is obviously considered the gold standard for qualitative research, but there are many logistical challenges in recruiting and doing in-person work in rural areas. So this was somewhat surprising too. Again, the pandemic has changed a lot of both the healthcare and the research landscapes. And so it'll be interesting going forward to see how those are further explored in the context of rural health. And I think I'm about out of time, but just briefly, this is some of the work we have ongoing in this area within our group at Mayo. So hopefully updating the review to incorporate COVID-era research, breaking out specific chronic diseases or geographic or demographic populations. We're currently doing a content analysis of patient portal messages and comparing findings by rural and urban patient residents, and then interviewing some of those rural patients to sort of contextualize this portal use. So that's it. I think I took most of the half hour because it's a lot of content, but thank you so much for the opportunity to share our study.
Well, thank you. Thank you, Dr. Kolumbiowski. Since we have very little time left, I'm just going to ask one question. If there was something that you had a rural doc in front of you, what would you tell him or her was the best thing they could do to help their rural patients? Based on what you've learned, what is the takeaway for a rural family medicine doc?
Yeah, definitely. I mean, I think my response would be similar to sort of the practices set out by models of patient-centered care, just knowing, I think having a sense of the community, avoiding making assumptions about your rural patients, but also recognizing that they face unique challenges to getting to you. I think, goodness, although, individual clinicians can't fix some of those conditions that would most dramatically improve the health of their rural patients, they can certainly take steps to sort of understand idiosyncrasies of seeking care and things that would enable patients to manage chronic disease in their home. And I think making patients feel comfortable and valued and avoiding some of those cultural stereotypes that I mentioned.
Mm-hmm, mm-hmm. And I'm sure we have physicians here who can comment on it, but I think we are almost done. I'm getting notices, and I think we really have a strong commitment not to take more than 30 minutes of our practitioners'
I know.
time. I would encourage folks who might want to provide Dr. Kolumbiowski with help and say, hey, look, I'm a rural physician. This is what I have encountered. Please feel free to email the participants. Please feel free to share, download and that Annals of Family Medicine article. I think, like I say, that we're out of time. I appreciate everyone's tuning in. And Sam, the rural health advocate, is not here, but he appreciates it also.